Okay, so for our closing keynote, it is my honor to introduce our next expert speaker, Dr. Sayida Peprah Wilson. Peprah is both a licensed clinical psychologist and a doula and birth worker. She specializes in multicultural psychology, trauma, suicide prevention, and maternal mental health. An advocate for human rights in childbirth, she is a member of the Black Women Birthing Justice Collective and a movement partner with Black Mamas Matter Alliance, promoting research, education, community-based services to positively transform the birthing experiences of Black families. She supports community doula efforts as a co-director, doula mentor, and a trainer for the Frontline Doulas and Sankoff Birth Worker Collective in Southern California. Dr. Peprah has served and continues to serve on advisory committee aimed at identifying key risks and opportunities for quality improvement and prevention around maternal health disparities. She is a founder and executive director of the nonprofit organization Diversity Uplift, focused on improving the well-being of women, birthing people, and children, and families by supporting marginalized and minority communities, while increasing cultural competency and humility among providers who serve them. Without any further delay, please welcome Dr. Peprah Wilson.
Perfect. Good morning. Oh, no, not morning. Good afternoon, everyone. I've been with you since the morning. This has been really incredible. I'm so impressed at the work being done and the intentionality even to have this day, the way that it was curated. We had conversations in advance to make sure that the topics aligned. So we would have Dr. Zaya starting off with, systemic perspectives, and then the panel, and then I come in to talk about the provider-focused aspects. So really aligned, really aligned. Oh, Guillermo, could you launch? Thank you. You guys have a great tech team, and I also think this building is amazing. I'm like, yeah, you're doing big things in Santa Clara, okay? Just in case people don't know. So I'll give you a little bit about me and just kind of center how I come to this conversation beyond just like the professional credentials. These are my girls who are 17 and 14 now. So I've had quite a spectrum of parenting and motherhood at this part in life. I myself was a Black infant health participant for both of my girls. I had WIC. I was on Medi-Cal. I'm not native to California. I'm from New Jersey and New York originally. So if I start talking fast and with my hands, that's, I try to keep it more toned down for California, but it comes through when I get excited. But I didn't have a lot of sense of the system here. I wasn't even on insurance when I got pregnant. I was in grad school, which I thought was a really great idea to have kids while I was in grad school. So I had to get insurance. And then at that time, you couldn't get insurance because you had a pre-existing condition, pregnancy. And so Medi-Cal was my only option. I couldn't have afforded anything else anyway. And thankfully, California has that as an option that you can have Medi-Cal when you're pregnant. But this is how I was entering in the system with no doctor, no connection. I don't know where things are. And so growing up, we had a local Planned Parenthood, which is where all the teens went, and which is where anybody went if you didn't have good insurance and a doctor, and they would take you and it was free. And I knew Planned Parenthoods exist. Let me see about a Planned Parenthood. Also, for context, the Planned Parenthood where I grew up didn't allow abortion. New Jersey wasn't an abortion state at the time. And so they were just preventative care. They were your local community provider, connected people, aunties in the community. And so I looked for one where I was, and right across the hall is Black Infant Health. And so there was somebody who came over to the Planned Parenthood waiting room where all of us would just sit and wait for, our time. If we were Black, they'd be like, do you know about Black Infant Health? There's this program. And I was like, anything, help, yes, I will take it all. Back then, you had peer level lactation consultants or peer lactation folks that would come to your home in Black Infant Health. I know they phased that out at some point. I'm still mad about that because it was really helpful. But I had challenges with lactation because it was my first time, and somebody from Black Infant Health came to my house and brought their baby and watched me put my baby on the breast and put theirs on and physically did a demonstration, and it saved my life. She brought cabbage with her in her bag. I was saved from my engorgement crisis that was going to turn into a big problem without her neighborly support. I know what it is to have the support of community. And even though I was an educated person, which at a lot of the times when I would go for services, people would say, well, you don't need that. Like, you're in grad school. This is for like different kinds of people. And I'm like, I don't know why you think getting education means you don't have a background where you need support. I also was still a poor person, even though I was in grad school, taking hundreds and thousands of loans to have a future. But there was a lot of even misnomer in the systems about like I being worthy enough to have access because I wasn't homeless or I wasn't in a really extreme predicament in the way that they were expecting. But as we know now, the impact of maternal mortality and infant mortality is not, you don't get protected by your education and your partnering and having money. And so that's something also that I always think about when I'm helping people think about bias and connecting folks to things. I also became a doula while I was in grad school, getting my doctorate in psychology, which I felt like I had to do because I was always somebody that people called, but I didn't know that it was like a full-on profession. And so when I became pregnant, somebody recommended I have a doula. Then having a doula made me realize I've been doulaing for years. I should do this officially. And so even before I got my doctorate in psychology, I became a certified doula and started doulaing. So I was also in school going back and forth to birth and grad school, and my professors and classmates were always like, you're doing the absolute most. But also they were fascinated, like, tell us more about birth, because we don't learn anything in the therapeutic world at that stage, at least. You know, so many bills and policies have come out to support education around perinatal mental health, but that didn't exist before. We were all just classically trained as though people don't also become pregnant in the course of classic mental health life. And then you have to figure it out on your own. And so I began teaching and training therapists and mental health folks around pregnancy and birth and the life experience of maternity. And then on the maternal care side with the nurses and the midwives and OBs and doulas, I was also teaching a lot about the mental health aspects. And so that kind of fused this world where I went from eventually working, full-time as a psychologist to doing a lot more in the maternal health fusion space and landed me kind of here today. So I want to know a little bit about who's in the room, just to give myself a visual of, like, as I give examples, I want to make them as tailored to the work that you do. So there is a Slido that it's a survey technology. So if you have a smartphone, pull out your phone. I'm going to do it with you as well so that I could follow along the process. And you're just going to, I'll leave that for a second to give folks a second to get in. And then it's going to, when I move to the next slide, give you options to select your profession. So I'm seeing if everybody's looking ready yet. Okay. All right. So it's going to show you the options as soon as I click over. Sorry. I know I was just like waiting for folks to get in. Okay. So if you're a care coordinator, doula, birth worker, educator, you've got options. Tell us who's in the room. You might be multiple things, so pick the one that you could live with choosing today. All right, so far I'm seeing a lot of nurses, program coordinator, managers, public health folks. The more people enter, the more it'll change. Mental health therapists, fatherhood, community health workers, care coordinators, other. If you chose other, can you yell it out? What is the other? Okay, thank you. Health policy, thank you. Okay, researcher. Okay, this is helpful. Thank you. We're going to do an exercise later. So this is also an activity of getting you into the Slido so that it's easier when we go. All right. So raise your hand if you have never done a training where implicit bias specifically was focused on. Okay, never. So most of us have and are very familiar or familiar enough with implicit bias, and that's good, so that I can get a sense of how deep to go. But I think having some foundational concepts will help us, because today what I want to do is actually have us apply what we know to a scenario, and come up with some of the solutions and practical things that we kind of heard some opportunities about this morning. So why implicit bias exists and why racism and understanding implicit bias matters. It impacts the relationships between providers and clients. We know this. People are not going to be consistent with you if they feel like you're disrespectful, if you're ignoring them. They're not going to be engaged if they feel like there isn't buy-in. Services between the patients and the clients or clients that you're serving, whether or not they're actually getting services can be impacted, the decisions that you're making when you're creating services, and whether or not it's effective, all the way from whether or not people feel harmed or whether or not it's helpful. And this could be all the way from microaggressions to outright abuse. And so we know that there's a lot of ways, but it does really impact the relationship that people have with their providers. And that's a first start to mitigate that relationship. It affects the morale. So it doesn't just deal with our clients and our patients and us, but also how we work together as a team. The relationships between staff and coworkers. If I am in a hospital setting, and if in order for you to get a medication, somebody has to move it up a notch, the anesthesiologist has to get on team. There's all kinds of people that are working in the background. If we don't work well together, maybe I'm not going to feel like I can ask that person for something that I need for a patient. If there's biases that are in the mix, it really also impacts how we can even coordinate care among ourselves. And then it impacts leadership. Leadership doesn't get information about what's going on if people feel like there's bias. Sometimes leadership is getting bias from people that are working with them because of some elements that are pushing up against each other's differences. So one of the things that has also been really important, and I feel like I don't have to argue this in this room because I can feel the buy-in that everyone has here in this county for work like this. But in the climate that we're in today, people are questioning if any of this is actually real, if it actually matters. And there has been significant studies that have demonstrated that healthcare providers, social work providers, those of us in the helping fields, our education does not protect us from implicit bias. We still track very similarly to the general population. And so one of the things that was indicated, they did a systemic review of 15 different implicit bias studies with healthcare providers. Low to moderate implicit bias / racism related to all the healthcare providers and all the types. And this is also not just for white providers to people of color, but to all the providers. So somebody said earlier, I had a black provider, but they had a white coat, kind of leaning toward people can still act in ways that are expressing discrimination, even if they come from the same community. We saw levels of implicit bias against Black people, against Hispanic and Latinx, against people based on skin color, so dark skin, negative preferences, and the like. We also showed that the patient-provider interactions and the treatment decisions and treatment adherence and the outcomes were impacted. So on all levels, what the provider does, whether or not people are going to work well with them, and then the overall outcomes. And then lastly, that people generally had more positive attitudes toward white patients and clients than they did toward people of color. And this was true not just for white providers, but for all providers. And I think it's really important so that we can make sure that we realize that everybody has to be in on mitigating their own biases to be effective. I do a lot of training with doulas and community workers who are people from their own community, working with their community, and we can get into a long conversations about biases just within the Black birth worker community or just within the Black community, different religions, different lifestyles, different family upbringing, different ways of seeing things, generational, it goes on and on. So all in all, nobody's immune to implicit bias. Whatever aspect you come into. I sit on the maternal mortality review for California, and I think a lot about how bias is so far up the upstream that by the time it gets down to you, you may not even know that you're looking at something from a biased perspective. So, and I'm saying this, the team that facilitates the maternal mortality review is extremely conscientious of bias and trying to mitigate that. And because of watching them do that and also talking with people in other states who have reviews and being with hospitals that are thinking about doing their own quality improvement, I think about the researchers, the people who are pulling data, the people who are sort of deciding which data to pull, what do they think is important. I mean, those decisions get made at a person level. And so if you don't have people who are mitigating bias at every level of our health system and public health, then by the time it gets down, all we hear is the statistic, Black women are 3 to 4 times more likely to die than white women. The statistic that we don't hear because of just the way that people are thinking of it is that white women in America are 3 to 4 times more likely to die than their white counterparts in all the other first world nations, right? The narrative that we're so used to hearing is Black people are dying and Black people are doing terrible and all of that, which is important because we want to know who our most vulnerable members of society are. But also people who are in a position to frame data and information for us, it is helpful when they're thinking about our experience when we receive the information and how it can have an impact. So a little bit about the psychology behind bias and stereotyping. So there's something called a mental schema, the process of organizing and categorizing information based on previous knowledge. We need this. It's normal. We would not be intelligent without it. It's a problem when we're dealing with social and human relations because categorization can be inaccurate, and it can also be paired with value judgments. So I say you're this type of person, and that typically comes with is it a good person or a bad person? And it almost goes to the juvenile level of like the way a child would think about the world. Is it good or is it bad? Our brains are often still trying to figure out in a very evolutionary way if this is a safe environment. Is this so? It's always like leaning toward an extreme polarity, which actually intelligence teaches you that most things are in the gray, that most things are multifaceted. So we're already mitigating this in our brain, even to like buy a car, to buy a house, like to make decisions for your health. Like we are prone to want to assume that there is one option when there are often many. So one of the schemas that we could all sort of relate to because it's very universal in many aspects, or at least is very pervasive, this idea that men, and there's a schema for men, that they're rough, that they're aggressive. And so with that schema being paired since childhood, the idea of a man getting a newborn baby and being the one to have to care for them by themselves could be scary to some people because they're thinking, well, how is he going to do it? Well, is his mother available? Is there a woman in the place that can provide the nurturing that a baby might need? Because there's a schema against males being nurturing, and there's a schema unless you have something that's counteracted that in your own life, in your own messaging, right? So there's opportunities based on what kinds of messaging we've been given in our lives. So if I say it has 4 wheels, it has doors, it has seats, it has a steering wheel, your brain does not try to go searching for every you're not wondering what that is. Right away, it's some kind of automobile, it's some kind of car. And the kind of car that you might think of is going to be based on the kind of cars that you've been driving in, etc. So there's also something about language that impacts bias. And this I find really interesting, the impact of language, because it's so in the subconscious sides that it's worth investigating so that we can be aware that if we don't have a language for something, we may not even be thinking about it. And things that we've created language for, we may be overthinking about. So I'll play the video, and then I want you to just think as you're watching the video, if you can identify any language that's used in the maternal health space that might shape the way providers think of a patient or a client that perpetuates bias. I wish that I was raised in that society. I'm so directionally not inclined. It's really terrible. I mean, I'm following the GPS and still getting lost very often. So I think you get the idea that Yeah, depending on concepts and phrases and language that we use, it's going to frame the way we think. So, what do you think of, and you can just call it out, in the maternal health space, phrases, language that we use that perpetuates bias, has us thinking of people in a certain kind of way, positive or negative? Black women are so strong. Mm-hmm. She's being aggressive. So we're looking for aggression. You know, the Black woman paired with aggression and Black male, somebody talked about it earlier, would have us be looking for aggressive Black male. That might be a sign of aggression. There was an interesting child study where they asked teachers to look at 4 children, you know, a Black boy, a white boy, a Black girl, a white girl, to see whether or not, what kind of biases teachers might have of children. And they gave them a scenario that there's something concerning happening with the children, and can they just observe to see if they notice it? And then they just show them a video of these children playing. And lo and behold, the Black children were doing something untoward, particularly the Black boy was expressing some kind of aggressive behavior in this one moment, which they had already analyzed for complete neutrality, and the same kinds of behavior among the kids. So we know that this happens, you know, at the young stages. Certainly it does in our spaces. What other examples? Baby daddy. Even having that phrase. Yes. So, and you'll hear that too, like people starting with that rather than saying your partner, or assuming that there isn't a marital relationship. And sometimes there's not, but just the over assumption. Absolutely. What about non-compliant? Having that term as a way that we take a note. I see that a lot when we're doing the mortality reviews, and the ways that folks reported people's, you know, behaviors. And of course, sometimes people are not able to attend a appointment that has been scheduled for them, maybe without consideration of how they could get there, and whether or not they have childcare, and whether or not it's reasonable. What other examples? What kind of things do we say that might perpetuate bias when we're thinking in the maternal health space? Yeah. Their English isn't clear. Mm-hmm. And of course, that being paired with being able to speak clear English, meaning that you're intelligent, and you know that you. Mm-hmm. Mm-hmm. What about somebody was saying yesterday for another conversation we were in, drug babies, teen mom. I heard that. Yeah. And just that, like a teen mom, not just a young mother or a mother, like having to designate it. What kind of person is this? You know, the need to, and it's difficult because we're trying to make quick decisions, because we talked about we have a systemic scenario where we have to do things fast, and we don't really get a lot of time for rapport building in our classic systems. But also there's a quickly make the assessment so that we can make a decision, which means that you have to basically quickly use a bunch of stereotypes and biases that you can come up with that seem to match this based on past behavior, or somebody who might have looked like them or presented with some aspects that are similar. So we know that having phrases and language and or not having the language. So for instance, when the ACEs first came out, it was all this adverse childhood experiences, very important work. And then somebody said, well, what about protective factors? Like, what about protective childhood experiences? Now that you have that, then you start assessing for it. Then when you start assessing for it, you see, oh, wow, there's all these things that actually mitigate the ACEs. Why don't we look for that, right? And so if you don't have the concept embedded, you're not going to be looking for it. Just something to note as we're thinking about building solutions. So implicit biases, we're just talking about the implicit, not explicit. We're going to get to that. And we're going to stay on interpersonal because we talked about systemic biases earlier. It could be positive or negative. You can have positive assumptions about people. These are subtle assumptions. They're usually subconscious beliefs. They often favor the in-group or your own group, the dominant group. And they don't necessarily align with our professed beliefs. We might say that everybody deserves to be given the utmost care, and I'm a provider that would serve anyone. And then somebody comes in and maybe they look dirty to you, or they have a smell, or you think they're on substances, or you find out that they have a criminal history of something that you have a lot of judgment around. And it changes the way that you actually engage, even if you would say, no, I'm fair to everyone. What's really significant about implicit biases, which makes it very pervasive, is that they're developed in childhood. Some of the early studies have shown that infants up to 3 months old have implicit bias toward people who look like their caregivers, which makes a lot of sense. You're the person who feeds me and takes care of me. You are safe. That means that people who look like you could be safer. It's very, again, evolutionary. If you imagine children that have multiple care providers or are raised in a diverse environment will have a different cue, right? So you could see how a lot of this is based on what is your actual background, which is why you have to know yourself to be able to assess and mitigate your own biases. Then we see that as children get older, into 3-year-olds, that they have interpersonal biases. They prefer to play with children of a certain background, and there are idiosyncrasies that are based in bias in early play. And if you have children, you might have seen things like this come up. And it's usually it's innocent. There's no intentional malice to it. They're often picking up on environmental cues of what other people are saying, and who their parents maybe feel safer for them to be around. So like cues around who parents allow them to play with at a park, or who parents smile at when they walk down the street. Like, children are picking up on all the things. And by the school age, if you're familiar, raise your hand if you're familiar with the doll studies that were done in the 60s. So they've been redoing them every 5 years. They did it in France not too long ago. Interestingly, across the world, people have the same exact outcome. And many of the outcomes that we saw in the 60s still pervade with young people in this generation. Where the Black children and brown children and white children all tend to think that the Black and brown dolls are the bad one and the ugly one and the less desired one. And then everybody feels more positive toward the white doll. Not always across the board, and there has been movement, but overall, this messaging of colorism and preferences, it pervades. So some examples of implicit bias, like how it shows up. Staring, eye contact differences, avoiding people, or looking at people more. So when people are actually doing studies to assess implicit bias, they actually will pay attention to how people are looking at a person and do, sort of like scientific study to notice where the eyes are showing attention and not showing attention. Physical proximity, how comfortable you are to be next to someone, or are you standing away? And also nonverbal cues. Are you kind of putting your arms together? Are you sitting back in a less engaged way than you do with people who you're leaning forward and more interested in? Or maybe sitting back for you culturally is, I'm very interested and relaxed. I'm here for all the questions you have. Go ahead and ask me the questions. And there's a difference in that posturing. So it's very culturally responsive, but it's about how you're engaging with people. Name judgments. So this is, hearing a name and thinking, people, I don't know, just all over assumptions. And there's lots of studies about people hiring people differently based on names that sound more, Anglo-Saxon than other names, foreign sounding names getting the most negative ratings on employment hires and things like that. And so you think about how that can impact. Care decisions based on perceived competency. So there was one study where they had a team of doctors that had to provide medications for a group. Let's just say they were on Medi-Cal. So low income. There was an expectation. They needed to provide medications that are effective. There were 2 medications that were available. One that was highly effective, but you have to take it twice a day. And the other medication that was also effective, but a little less effective, was a once a day. And they chose unanimously to just offer only the once a day medication to the population, because they thought, well, they're not really a very compliant population anyway. And so let's just make it easier for them. So in their minds, they're thinking, I'm being helpful. But actually, you're just assuming people's competency. You're making decisions for people about their health care. And that's just at a small level when you think about how people can make decisions that ultimately people would never even know they had the option. Being dismissive and devaluing, and also having biased conceptualizations about illness or the need for treatment. Oh, I don't think it's that serious. Oh, it's probably just. So one thing that we see a lot in the maternal mortality review with people with substance use. So there's a history of substance use and they're coming in for some kind of like cardiac problem. And the whole chart, well, history of meth, and then meth this, and then meth referral, and all of these things about the drugs, but not necessarily all the appropriate tests to figure out whether or not this person is having a present and active cardiac concern. And so same thing with obesity. People with a high BMI and the whole, you say obesity, probably obesity. And you're like, sort of like, they're just assuming that everything is related somehow to the obesity and not actually looking for other medical needs. So there's ways that your biases can completely skew you from looking at and identifying actual problems. And then things like pain, which we know, like people assuming that people aren't in as much as pain as that they are, or that they're over exaggerating. And so, well, you know, I don't know if it's that serious because, you know, they would really be screaming, but maybe this person has a really high, you know, pain tolerance, or people complaining of pain excessively and people thinking that they're over exaggerating and saying, well, no, it's probably, you know, not that bad, or, you know, and not wanting to mitigate pain. Then we have explicit bias. So this is less common, but it's important to note the differences because I always want people to know that you could say, if you want, that I'm not a racist and I don't have explicit biases. One might be able to say that, but you can't say that you don't have implicit biases. Like they are something that is a part of our brain structure, and you can mitigate them and you can be intentional and you can actually utilize cultural humility and empathy in a way that really mitigates biases that might come up, but you discount them. Oh yeah, I have seen 17 different people just like this person that did this. I will put that as a note to self and let me see what's actually in front of me. Let me see who's actually here, presenting here. So for explicit bias, it could also be positive or negative. These are gross assumptions. These are overgeneralizations. These are conscious beliefs. Some examples: harsh looks, rolling your eyes, right? Not like just avoiding someone because you're uncomfortable, but I don't like you and I don't care if you know that I don't like you. Refusing to shake somebody's hand. Mocking someone's name. So these are obvious things that people are typically not displaying. It does happen, but it's not typical. Differential care. We're not serving people like that. There is no value. If they died, the world could be a better place, right? That kind of really outward, disrespectful lack of care for humanity. Ignoring willful negligence. So I heard this person say that they had pain. I heard this person say that they saw blood in the catheter. Well, we're moving on. That there maybe not, this is not the priority for this moment, right? Bigoted judgments, having very specific people that you don't like to talk to, you don't want to work with, that kind of thing. Again, most people don't have that, but it exists. And that's the difference to note between the two. So then when we talk about types of biases, there's a halo effect, which is allowing your judgments to be influenced by a particular trait. It could be negative or positive. Somebody comes in, they look scruffy. Right away, you're thinking, oh, they probably are not going to take care of their health care. I'm probably going to have to give a lot of examples. I'm probably looking for somebody to have problems here just off of this one thing. Or, oh, they came in with a suit and tie. They must have everything together. They must be really organized. I think that the halo effect actually really impacts Black women a lot because we often present very high functioning when we are also still struggling. So I'll hear a pediatrician say that they miss the cue for checking for maternal mental health concerns because they're asking, well, how are you doing? How are you coping with the baby? And they're like running off the things that they're doing and they're taking care of business and they maybe are stoic and a little bit flat, but not crying when the door shuts. And oh my God, I just can't take it, because that's not a typical presentation for someone that might have been oriented within culture to have to be the one taking care of everyone and maintaining a strong stance. But also, how are you going to cope in the next moment if you're falling apart all the time, right? And so people who are oriented toward that strong Black woman syndrome that we've all heard about and know about, this can really disrupt people's perspectives when they're seeing us present. Now, that doesn't mean I'm saying you have to go and cry in the office. I do like people to express their emotions if they have them as a psychologist. But it means that providers and our systems need to be not looking for one particular way that people present when we think that they need help. and really finding ways that are culturally responsive to assess for things. So one of the things in the perinatal mental health side, when we do screenings, and this is something that a lot of us have adjusted for, and then we've talked about afterward, like in studies, but also in running our programs, that we either found ourselves lowering or raising the threshold for the number of things that people would be scored on for, like the Edinburgh, for example. So if a Black woman reports, for example, a higher number than other folks on issues that they're having, some people would have interpreted that as another person might have needed an extreme referral, and they don't need a referral in the same way because they're actually coping. Their baseline is, I've got more than I can handle. I have difficulty sleeping. I worry a lot, but I was doing that before I was pregnant. And so this is my baseline, and these are the other things that are added. So really understanding the person is very important to understand like where they started from to where you're assessing. But then on the other side, people would note that people might say, well, no, I don't ever feel hopeless, because they have a lot of faith. But maybe they don't feel hopeless because they assume, yep, I'm going to have troubles and I'm going to have struggles and I'm going to survive and it'll be fine. But yes, I'm struggling, and yes, I'm having a hard time. So even some of the ways that things are rated, people have had to change things so that they can get a real reflection of what people were experiencing. All right, affinity bias. The preference for those that are similar to ourselves or a part of the in-group. So, women feeling more comfortable with women, men feeling more comfortable with men, all the things that you can identify racially, religiously. But this could be a problem because you might assume that you know a person because they come from a cultural background similar to you, and then you make a mistake about that. Or you are not looking for some concern because they're coming in with a partner and you, within the culture, recognize that marriage is a strong suit. I'm thinking of a story that an Indian woman had told us, that her doctor came in and she didn't have a husband. And so she was like, well, I'm waiting for your husband to come so we can, start the meeting. And she's like, oh, I'm not married. And she's like, well, we don't do that. To this Indian woman. It was an Indian doctor to an Indian woman. And that woman proceeded to change doctors because she felt like, I definitely don't feel like I can be safe here because this person is really over assuming that they know me because we're connected in a group. And then confirmation bias, when people tend to favor information that confirms what they already believe. And now this is a problem because that means that everything that you might have had a bias toward, you're prone to want to confirm in your mind. And so even if you see an exception, the brain is like, that's an exception. Probably not true. And unless you have enough exceptions where your brain registers that there's an error, I actually don't understand the world because everybody is not bad because they look like this. Every person in a hoodie is not going to rob me. Every person, that presents in this way is not following the schema that I have, then it allows for a disruption of the schema, which is why having overexposure to diversity, to different experiences is important. And what's challenging in the healthcare system is that the people that we often see need our help. So people are coming into the hospital because they're sick, because they're needing more support, because they're in a situation where maybe their health isn't at the best. So we're not seeing enough of people who are maybe higher functioning, who have balanced health care. And so we actually can have a confirmation bias just by who we're serving all the time. So sometimes I'll see this with like ER doctors or folks that work in an inner city hospital, but they're, living in another community, and they feel like, I know this community. I'm in the hospital with these people all the time. And it's like, well, you're in the hospital with people in the hospital, but you're not in the grocery store with them. You're not at their, spiritual services. You're not in community space. You're not with them when they're in the park playing with their children. So your perception is people who are anxious, people who are agitated, people who don't have a lot of time. And so that also really skews a lot of our health providers because, and social workers and therapists and many of us that work in press spaces, because we're over stimulated by people who are in need, and we don't see the resilience and the coping that they otherwise would have when they're not with us. And then there's all these other ones. There's ableism, there's ageism, there's bigotry, there's colorism. We talked about that. Dominant culture bias. I like to say that, anti-white racism is an important phrase as well. But I like to think about that because the dominant culture bias we see across the world. right? So if you are a heterosexual person and you're in space with people who are in the LGBT community, you could have dominant culture bias, right? The dominant culture is heterosexuals. And so people are thinking in this binary in that way, and they're not thinking about other people. Sometimes you're in an environment where the minority for the general population is a majority in the community where you are. And so that is the dominant culture, and you could have a bias with other people who are minorities in that culture. Then we have, ethnocentrism, just really this belief that one's ethnic group is superior. So judging other people's cultural aspects based on your superior ethnicity or perceived. Heterosexism versus heteronormativity, and that versus homophobia and transphobia. So this is going back to the idea that people are expecting there to be a binary. They're expecting that, a person came in, they have a husband or a partner, and that partner is a male. And so that is not intentionally malice or trying to ignore someone. It is reflective of the dominant culture. Now, if you're homophobic and you have irrational ideas about people, you don't want to create a space where people feel safe in your environment because you don't want to serve people like that. That's where we get into the phobia parts of it. Microaggressions, folks are familiar with. Sizeism, lots of that in the maternal health space. A lot of bias toward people with elevated BMI. And then xenophobia, being afraid or having adversity around people who are from outside of your environment or who are considered to be foreign. So we're going to watch a video where there's going to be a story told about a person experiencing the maternal health landscape. And I want you to listen for some of the biases that I mentioned. Now, you're not going to have to know them by memory. You're going to have access to a Slido so that you can look at them by description and think of them after. So we're going to watch the video and then we'll queue up. But I just want you to be thinking as you're watching, what do I see? What kind of biases am I noticing in this storyline?
Dana is a 28-year-old cisgendered Black woman who is 39 weeks pregnant with her second baby. This has been a low-risk pregnancy with prenatal care throughout. Her first pregnancy had been uncomplicated with a spontaneous vaginal delivery at term. This time, Dana really desires the care of a midwife and possible home birth, but when researching, she found none in her local area. Because of this, Dana is receiving care at a local hospital covered by her insurance that is discovered from some reviews through the Earth app. The hospital employs midwives, including one Black midwife, but the group is still small, and she was aware that she may not be able to birth with a midwife when labor begins, depending on their schedules. Dana now presents with her husband Malcolm to the hospital after laboring at home with contractions that continue to increase in intensity and frequency in the middle of the night. She is informed while checking in that none of her midwives are on call this evening. The doctor on call came to assess her and immediately said, "Oh, I haven't met you before." He proceeded to start examining her in the middle of a contraction without explanation and despite Dana's request to wait till after the contraction. He insists, "Well, they're just going to get stronger and you'll miss your epidural if we can't evaluate you now. And I need to check your cervix now if we're going to admit you." Dana continued to breathe and focus through the contractions that seemed to hit back to back. After the contractions finished, she let the physician know that she was not planning for an epidural and would like to move around the room to help facilitate her birth. He bristled, "Fine, whatever," and walked out without another word of explanation. Dana's nurse entered and asked if she could examine her cervix when Dana was ready. Dana agreed, and she was found to be 8 centimeters dilated. The nurse exclaimed, "I wouldn't have known. You have so much control." She proceeds with the admission process and then explained that she would leave to gather some supplies. About 30 minutes later, when no one had yet returned, Dana told Malcolm she felt like pushing. Malcolm called the nurse through the call light and told her that he thought the baby was coming. The nurse said she would be right in. However, Dana and Malcolm, as they waited, could hear laughter and someone say, "Oh, she doesn't know what she's talking about. She just got checked. And she was 8 centimeters. Someone else replied, "We should have just given her the epidural then. At least you would have had 2 more hours before the delivery." With sinking disappointment, Dana focused on her contractions and pressure. Although upset, Malcolm continued to support Dana through her labor. About 10 minutes later, Dana's nurse walked in to find Dana actively pushing and saying, "The baby is coming." The nurse lifted the sheet to find the baby's head crowning with a tuft of the baby's hair already visible. She called for help from her nursing team to alert the doctor for delivery. As this was happening, Dana let out a large grunt, and her baby quickly emerged onto the bed before the nurse could put gloves on and the doctor arrived. Their vigorously crying baby was immediately scooped up by the nurses and handed to Dana. At that moment, the doctor entered the room exclaiming, "Well, that was fast. You're lucky." Dana asked that the doctor delay clamping the umbilical cord, but he replied, "Well, it's been 2 minutes already." Dana felt too exhausted to fight further, so Malcolm went ahead and cut the cord as instructed, and without asking, the nurse immediately took the baby to the warmer. At this time, the attention focused on a new concern. Dana was bleeding heavily. The doctor began to give orders and asked for additional help. Without warning, he stuck his hand in her vagina and Dana screamed. The doctor continued saying, "I have to stop the bleeding. I can give you something for the pain, but we need to stop this now." The bleeding continued. Dana was beginning to feel weak. Her heart rate was picking up, and the pain was intense. She asked the doctor for medication, and he replied, "Well, you had the baby without anything. This will hopefully be over in just a few more minutes." Dana was too tired to cry. Malcolm could see this and asked again, "Are you able to give Dana something for the pain? This is too much for her." The doctor sighed and called out orders for the pain medication. When the bleeding would not slow, urgent preparations were made to take Dana to the operating room. She was quickly consented and whisked away. Malcolm was left alone, holding their newborn. While Malcolm waited for Dana to come out, a nurse walked over with a bottle of formula. "Here, give this to the baby. The baby needs to eat," she said. Malcolm knew just how important it was for Dana to breastfeed, and the baby was calm at this time, just looking around. Malcolm said, "We plan to breastfeed. I would like to wait a little while." The nurse rolled her eyes and said, "Are you sure? She might end up supplementing anyway." Malcolm said he was sure and asked her to help him with skin-to-skin contact. After some time, a different doctor came to speak with Malcolm and said that Dana's bleeding was finally under control after some extensive work, including a balloon that helped to prevent more bleeding. He stayed to answer all of Malcolm's questions and list out a plan of care and a medication regimen to help her with healing and pain. Malcolm thanked the physician for being patient and explaining things. Dana recovered well and was able to go home about 3 days after her birth with Malcolm and their newborn.
Okay. So I'll just do a free feedback loop because I heard all the mumbles. What did you hear? What jumped out at you that was concerning? Dismissive, uncaring, not listening, not believing, assumptions, lack of consent, a lot of lack of consent, dismissing pain, disrespectful, rolling eyes. Yes. What was your? You had something? Showing no sympathy. Yes. Yes. Even though she was in a lot of pain. Yes. Believing that they knew more about her than she knew about herself. I saw someone's hand over there. Yes, there we. That was it was a consistent disregard among providers at many points in the care. Did this seem like a completely irrational story that you heard? No, right? Like it's like all these things were like, oh, yep, I've heard that. Oh, yep, I've experienced that. Oh, yes, I've observed this. So let's, using the Slido again, and it should just open right up now that I've clicked onto that one. Let's see, make sure it opens up on my end too. Yeah. Everybody got it? Okay. Somebody need to get in again? Okay. Oh, I'm seeing something different than you see, and I didn't realize you could see the QR code here. This is great. That's what I was hoping. You could see this. Lovely. Okay. So collectively, but on your own, so we can capture it. What kind of biases did we see? So just go ahead and take a minute to click on all the things, and you should be able to click multiple that you saw in this story. All right, we got 54 responses. It's still going up, so I'll let you keep going. Hopefully this is working for the folks that are online as well. I try to create something so that you can interact with us. All right, we still got responses growing, 89, 90 people. So I'm seeing a lot of willful neglect, ignoring and willful neglect, dismissing, devaluing is at the top, implicit bias, interpersonal and systemic, some explicit bias, interpersonal, a negative bias, care decisions impacted by bias, subtle assumptions, subconscious beliefs, gross assumptions, conscious beliefs, explicit systemic bias, overgeneralization. So basically, we felt that this was a good example of a lot of problems. Okay. Great work with those examples. One of the things that I also love to center, because it really helps us think about both how we can help people advocate, those of us that work in community space and are like working with people going into the system, but also how you can advocate if you're in the system, for your system to actually treat people at the level of their rights, is to consider the Black Birthing Bill of Rights. And I think this about all things that are, that are Black-centered because of the disparity and the need for the community to come up with something that solves the solution that we're needing. And it benefits everybody. These are human rights. These are based on general human rights that people have, and that have been reviewed by attorneys, and it has been agreed. And of course, human rights are not agreed by every government, that people even have the human rights that people have agreed that one should have. But these are things to think about. And I think about this when I think about that story. So the right to be heard and respected, we already saw that was missing. The right to informed consent and refusal. The right to high quality health care. The right to choose your birth setting and support team. The right to emotional and physical safety. The right to transparent, honest communication. The right to accountability and recourse. The right to culturally centered care. The right to autonomy over body and birth. And the right to breastfeed or not. So in the story that we heard, almost all of these were impacted, even the issue around the right to breastfeed or not. The lack of consideration for the fact that this person is saying, no, my partner intended to breastfeed. If there's no reason that this baby is going to pass out at this very moment, and all of us, in this work know that babies are not starving when they come out of the womb and are going to pass out if they don't have, you're talking about within an hour or two of what was happening here. It's lovely to get baby on breast and cuddle time, but it's not because they're starving. But there is this, pretty strong automatic response that people tend to have, that we see if they're not centering people's right to lactate and to manage that on their own, and support around that. Maybe some communication. If there was a reason why they were concerned, say something to the partner about why you're recommending an immediate feed, and consider. So some things around techniques to engage in cultural humility. So we know what biases look like. We know that it can be problematic. And how do we mitigate this in our own stance as providers, as care people? First of all, we need to understand the common assumptions that we make. We need to understand our own biases. And I'll, we don't have all day, but I have an exercise that I think is really helpful called cultural scripts. So I'll share that with you. It's something you could do like homework for later if you want to take this on for yourself. Practice perspective taking and individuation. So I gave this example earlier. I know I work with a bunch of people who have a similar presentation, but what is happening with this individual in front of me? Is there something that I can center about what they're experiencing? Can I lean into their interpretation of what's happening here? I always love that. Even someone who has done thousands of assessments, and at some point you become very accurate when you're a clinical assessor, but that doesn't mean that there aren't times that you recognize, oh, I made this assumption, and that could have totally skewed my ability to really center this individual. Tune in and respect other people's worldview. People have worldviews that are very diverse across. Your own brother or sister or family member could have a different worldview than you. None of our worldviews, ideally in the multicultural perspective, are right. They're just different, and all of them are different. And some may be dominant cultures, so a lot of people have the same worldview, but just being mindful to consider their entire worldview as a way to understand what's happening with them in their lives, particularly around their health. Like, how does this impact more than just this moment in their physical body, but how do they see their health in the course of their life? So for instance, you're wanting them to come into care or wanting them to change a dietary situation, but for them, their priority is finances or housing or just coping with their emotions. And so therefore, overeating is something that is an aid to them in their life. So understanding like what is actually happening in their entire worldview so that you can mitigate not just the thing you're trying to fix, but also what other things are important to them as a pathway to a whole wellness experience. Being curious always has the brain turn itself on to new and turn itself off to biases. So that's one like small trick is like, oh, I'm really curious to know if there's something here that I haven't expected. Like, especially if you're in a habit, if you have I get 15 minutes and I have to make a decision life, or you kind of have a fast turnover, start with curiosity when you're engaging with people so that your brain can start looking for nuances and distinctions rather than doing the confirmation bias. Yep, I figured that. Yep, I'm sure that probably happened. Oh, yep, it looked like this is happening. It makes it very difficult to be able to mitigate it if you don't utilize curiosity first. Engaging in intercultural and cultural immersion experiences, very helpful so that you can have those opportunities where your brain says, this is actually not true. I've met now 5 or 6 or 10 or 20 people. I've come into a whole community that has a totally different experience than I thought. It creates a level of suspicion that has you think, I'm going to engage differently. Now, in a practical way, if we ever as children engage with a cup, and nobody ever gave us hot cups, right? So you got a cup and it was apple juice or it was water, it was a bottle, it was something. And then the day that you get handed a hot cup, that correction that I have to check before I pick something up makes it so that you stop engaging with cups as though they're all the same. So there is this thing that happens in the brain that will turn on consistently if you can really overly acknowledge when you have a discrepancy. So one cue is, you met someone, you work with a lot of people, and then you meet a new person that is so different than you expected. Really let that land in your brain so that you can keep that memory alive that I was wrong. I was inaccurate. Even let yourself imagine if you had gone down the path of making the interpretation of what you thought it was and you were wrong, how bad it would have been. I would have missed this cue. I didn't even realize they had other children in the home. I didn't realize that their partner was ill and that's why they weren't coming. I just thought that it was just somebody who didn't care about their partner. I didn't realize they had this transportation issue. I didn't realize that they were in working 3 jobs. I just thought that they didn't care about their health care. Like really center the contrast that you experience so that your brain can want to do more of that. Deepen empathy, heart really overacts over the mind. If you feel pulled into something, people will help people that they would say they otherwise would hate. But that person's baby is in the water and you're standing there and you can swim, you're jumping in for that baby. And you might in your mind think, I don't like people like that. If I knew that was, a racist child, maybe I wouldn't have jumped in for them. Like, no, your heart tells you this is a baby. This is a human being. And I love the stories of people who find themselves in bizarre scenarios and have to do survival with somebody that they otherwise would have never spoken to. And then they realize, oh, I could be different. So if you lead with your heart, which sometimes people get burnt out over time in our fields and forget to lead lead with the heart. I want to, before I take any questions, share about the cultural scripts. So there's a concept called cultural scripts, where basically how you engage with the world and also how the world engages with you is often very dictated by your presentation in the world. Both things that are obvious to other people, but also things that are internal toward you. You've traveled a lot. You're a military kid. You only grew up in one little small community. You only had one religious experience, or you've lived in a bunch of different places. You are, a tall person. You were a popular person. You're very introverted. You're very extroverted. There are all types of things about our sort of greater personality, our cultural script, that does impact the way that we see other people and the way that we engage. And if we can understand how our background can create hangups for us, then it really helps mitigate it, because I already know that where my potential falls could be, because I've done a lot of work to look at what my background has taught me that makes it so that I have a narrow perspective about something when I could have a more open perspective. And then you do the work to move it. But if you don't really assess yourself, you may not have the chance to really understand where you have limitations. You might over-assume that you have openness in areas that you don't know. And it gives you an opportunity to sort of take yourself on. It's free, there's a video where you can watch it, and it explains how to do it. And then you just kind of map out your own cultural script, and then look at ways that you, that is a lens through which you provide services and interact with other people. All right, well, I will stop here for questions. Thank you.
Thank you, Dr. Peprah. That was wonderful presentation, and we learned a lot. So if anyone have any question, we have time for one in person. Anyone here have any question for presentation, Dr. Peprah?
Or comment or
Comment.
thoughts.
Sure.
Yeah.
Okay. And then we will also take just one more question from online. So Rania, if you have one, you can go ahead. Yeah.
All right. Thank you so much, Dr. Sayida. That was a beautiful presentation.
Wait, can you raise your hand? I can't see where.
Okay.
Oh, right over here.
Thank you. Okay.
Yes. All right. I'm going to be giving a question from the online. So there's one question here that asks if the video that was shared is available.
Which video? Oh, which video? The first one or the second one?
They did not specify, but I will assume that it's the second video.
Okay. Yes, I believe that they have it posted on YouTube. So that actually is a video that was done by Deidre Consumpos Medley, who's in the Inland Empire. She's a doula, and she also creates doula trainings. I believe that she has it on YouTube, so I can share it with the team and then make it available if it's available.
Perfect.
Yeah.
That sounds great.
Okay.
And then,
Then we would have.
Yeah. Hi, I'm Dr. Mahari. Thank you so much, Dr. Sayida. That was an amazing lecture. I've learned so much. I hope you come to my department and give that lecture again. I did want to ask you about therapy. Therapy is also so Eurocentric and not culturally sensitive. So what are those biases and how do you mitigate those?
Yeah, that's actually I love that question, because I was just having this conversation this week. We had a community doula training, and we were talking about what do Black women need in general for emotional support, and the fact that therapists are not really available, right? Like, it's so expensive and it's very difficult. There are some, and raise your hand if you're a therapist in the room and you're available. Well, good to know. But you often will see like one or two people like, hi, I'm here and I do provide services, but they get very full. I don't know any, especially Black therapists, that is not with a completely full, like wait lists on wait lists on wait lists. So I'm always like taking students and trying to make sure they get connected with supervision so they can become available. But what I will say though is that what we do find is that group, like postpartum and pregnancy support groups, group-based care, which very much mimics like community conversation, like sister girl time and healing circles. During the pandemic, I was asked by March of Dimes to lead some like birth healing circles online, just to give people a space after Black Women, Birth and Justice in the iteration of the Battling Over Birth report, which actually I could show you. So there's the Battling Over Birth report as a story of 100 Black women's stories and experiences in maternal health. But how we did the research is that we actually had everybody in the living room just sitting together talking about their birth experiences, and then recorded it and turned it into a research study. It was intentionally done that way, but it felt for them like they were having a sister circle. And there was so much healing that happened, even just with them telling the stories, that people really saw like maybe that's just an option that is outside of what we think of as like a therapy group or this ongoing thing. Just having moments where people can come and tell their story and receive empathy and normalization and that kind of feedback that tells you that you're not alone. And interestingly, out of those, a number of birth workers were grown out of it, because some of them had had so many bad experiences. But then when they realized that there are people who make it their business to support people to not have those experiences, it felt like something that they could do to give back in a way that was something that they wish they had for themselves. So I do think that there's a lot to be said about culturally responsive mental health and emotional support. I like to center emotional wellness and like mental wellness as the way that I have the conversations, because it's strength-based. Because if you say mental health, then now we got to look for a diagnosis, and then we have to find somebody to diagnose. But if you give, a person a basic questionnaire about the level of stress that they have in their lives, and understanding like, how do you cope when you're in your worst situation? How does that look? How do you get through a day when you have no energy when you wake up in the morning? Just having those kind of normalized conversations then kind of help people figure out how to cope as things progress in pregnancy and maybe can get challenging. And you'll know the difference between their normal baseline, which I find that even as a psychologist, and I was trained with the multicultural community perspective, so intentionally, so that we could work with people who were outside of the dominant culture. And so it was a lot of like specialized study in different cultures, ways of beings, which also still like everybody's not the same, and there are some nuances. But overall, I have found that having those individual communications makes a difference in doing it in groups, because people get to hear other people's experiences and feed off that. So thank you for asking that question.
That's wonderful. Yes, one more question. Yes, yeah.
I had a question for you too earlier, and I was like, I shouldn't ask the question.
Here in California, a lot of the anti-Black racism is actually being perpetrated by non-white people. And very often when we talk about implicit bias, it's very much constructed on like a black-white binary. Yeah. But what advice can you offer for folks who experience racism to not also perpetuate anti-Black racism?
Yes. So internalized racism, which I feel like is what Dr. Zaya is really speaking to, is, the fact that if you're raised in a racist society, you yourself have received the same messaging that everybody else received about your race or other people of color and minorities. And you could also perpetuate, we see in research, people still perpetuate that. So I think being aware that that's a thing, so I have in my own spaces, in the nonprofit, in the programs that we support, lifted that up particularly in Black spaces and spaces that are BIPOC intentionally, so that people are aware this is not somebody else's problem. Because I have been in spaces where people are like, I don't even see what the point of us having this conversation is. Most of us are Black and brown. And I'm like, guys, and so one thing I'll do, religion is an easy one for me to get people of color, because there tend to be strong, dominant religious groups among people of color. And so I'm like, okay, have you ever heard of a Hebrew Israelite? Some people have, some people haven't. Do you know what their beliefs are? I've had people, very well-meaning community-based folks that are like, they have candles and incense in their house, and I don't feel comfortable with all that devil worship. I don't think I can work with them. And I'm like, okay. We have work to do, right? Because people have strong biases culturally that go against this, like the skin color doesn't even make a difference. For some people, it's cultural elements or religious elements or things that are more pertinent to them. Obviously, working with LGBT community is a big issue. People have, I always try to remind people like our communities are diverse, which means that every Black person isn't, the classic Baptist that, whose family is from the South and then they moved here. Like there is diversity. Some people are from Africa and they are second or first generation. Some people are from the Caribbean. Some people are mixed, like my kids who are, Ghanaian and African American, and that's really strong for them. Like they feel like they don't get understood because they are more dynamic in some ways of their cultural identity than other people who look like them. And so, I think just lifting this up, like letting this conversation not just be about a Black and white, it really does us a disservice, because at the bedside, that person working with you is going to be seeing you as who you are as a person, or they're going to be working in judgments. I know you're telling me it's time. Thank you all.
Thank you so much. And I just want to let you guys know that this presentation is recorded. So everyone who is attending, register, will get the copy of the recording.